Hi, everyone. I'm Sri Avadhani. Thanks for having me here. No relevant financial relationships. So I'm here to talk to you about acute limb ischemia, which is defined as a sudden decrease in limb perfusion that affects the viability of the limb. Usually the symptoms are within 2 weeks of presentation, although they can occur over the past few days to hours and can range anywhere from worsening claudication to rest pain and a whole spectrum of neuromuscular symptoms from paresthesias, muscle weakness, to even paralysis of the limb. This should be differentiated from chronic limb-threatening ischemia, in which case there's time for collaterals to develop and generally, even though the limb is threatened, less urgent than in the case of an acute limb. So urgent recognition and revascularization in ALI is crucial. Just to kind of go over the scope of the problem, a lot of the data we get from this huge prospective study of 90,000 patients in UK that were followed over 10 years basically shows ALI is associated with significant mortality and morbidity. As you can see, 200 patients who were followed, initially 60% of them were independent before the event, and just at 6-month follow-up, 70% were either dead or dependent, and at 5 years, this was up to 89%. Risk factors, generally the traditional cardiac risk factors of age, hypertension, smoking, and diabetes predicted these ALI events. Also associated with significant mortality, overall, the study looked at patients with acute visceral events, ALI, and CLI in general. Although the visceral ischemia tend to have the worst prognosis, ALI as well, overall survival at 30 days was around 75%, and at 5 years, 55%. And similarly, poor rates of amputation-free survival and significant limb loss as well. Time is limb, and the sooner you can get these patients recognized, identified, and revascularized, the better their prognosis is. As you can see, the amputation rate significantly goes up the longer you wait. 6% if they're revascularized within 12 hours of onset, goes up to 20% when it's after 24 hours. And the mortality overall, based on a few studies, similar to a patient with an acute MI. What are the etiologies? Primarily a thrombotic disorder, meaning in a patient with chronic PAD, the patient develops in situ thrombosis from either plaque rupture or plaque erosion. That's usually 85% of the causes, but a small portion also suffer from embolic etiologies like AFib or LV dysfunction, in which case clot from a different organ embolizes to the leg. And there is a difference in prognosis between these two because in a thrombotic etiology, there's underlying PAD, and there's generally room and time for collateral development, and you generally have better reserve than if it's an embolic cause. Other less frequent etiologies, you want to look for thrombophilias, vasculitis, trauma, graft thrombosis, vasospasm. All of these also do cause ALI. In terms of significant history, in addition to the duration, you also want to look at the severity of neurologic symptoms because it kind of determines reversibility of ischemia. Also their functional status, Rutherford class, if they have any contraindication to lytics, and also their comorbidities and prior surgeries or interventions are important as well. The 6 Ps that we talk about, important to recognize any signs of pain, pallor, impaired body temperature regulation, pulselessness, and in general, the neurologic symptoms of paresthesias and paralysis are generally a late sign. The severity of ALI is categorized by the Rutherford stages 1 through 3. Generally, stage 1 is the limb is viable, they're symptomatic, but it's not immediately threatened, and there's no neurologic deficiencies, and you have good Doppler signals. In stage 2, they separated between 2A and 2B. 2A is a marginally threatened limb, meaning there's minimal sensory loss, but in general, there's no muscle weakness and your Doppler signals are intact. But 2B is where you do want to recognize it because it's immediately threatened and the limb is actually salvageable if immediately revascularized. The sensory findings involve more than the toes, and there is some degree of muscle weakness, and generally an audible venous signal, which differentiates stage 3, in which case the limb is irreversibly damaged and you have no audible arterial or venous signals, and generally the sensory and muscular loss is pretty profound. Some diagnostic modalities. Again, this is kind of institution dependent. Generally, the go-to is a CT angiogram. It's readily available in most ERs. It gives you all the anatomic information. And also nowadays gives you a 3D reconstructed image like you see on the right. However, if you are bringing the patient to an angiography suite, it's additional contrast dye, radiation, and especially in a patient with renal disease, you want to decide if it's really going to change your management. Some places also use a duplex ultrasound, although this has limited information, especially with bowel gas and things like that, to look at the aortoiliac system, or especially if you have very calcified vessels as well. And MRA also gives you anatomic information, but it's not readily available as well. In terms of management, traditionally, before a lot of these endovascular techniques have come up, the treatment modalities were either surgical, where the surgeon would directly remove the thrombus, and also either some sort of surgical correction, whether it's a bypass or a patch angioplasty. However, this is invasive, and up to a third of patients still have residual thrombus after surgical intervention. In a patient who has contraindication to lytics and poor functional status, medical therapy is also been used with anticoagulation and supportive care, but I'm going to talk to you in the next remaining time about all these endovascular techniques that have been used for thrombus treatment. In general, some of these studies from the mid-90s have looked at surgical versus endovascular, predominantly catheter-directed lysis, where you take a catheter and you're locally infusing TPA, and basically found that in an acute limb where symptoms less than 14 days, that there's no difference in outcomes, but no superiority of thrombolysis over surgery in class 1 and 2 ischemia. This meta-analysis also kind of pooled all these studies and looked at the outcomes. Again, no difference in mortality up to 1 year, no difference in recurrent ischemia, and the amputation rates were the same between the two groups. So in terms of endovascular therapies, one of the most oldest therapies we have is catheter-directed lysis, usually indicated in class 1 or 2A with minimal symptoms, where you have an infusing catheter that you leave that's kind of infusing lytics over time, and you reassess a patient from time to time to see how they're doing. But in general, it's non-traumatic. It's best if it's a recent thrombus, less than 14 days old. However, as you know, there's many contraindications to lytic therapy, and the risk of bleeding is not insignificant. Again, it doesn't work as well for organized thrombus or late presentation, stage 2B or 3. And about a quarter of patients may need bailout surgery after lytics. These are some of the lytics and doses that we use. Another modality is ultrasound-accelerated thrombolysis. So this is pharmacomechanical, where in the catheter basically emits these ultrasound waves. It's the ECOS catheter by Boston Scientific, and also has these ports that infuse the lytics as well. So in addition to pharmacologic breakdown of the thrombus, you also have this mechanical, the ultrasound waves seem to break up the fibrin strands and make it easier to dissolve the clot. It does seem to decrease the treatment time and dose of the lytics that are used. The revascularization is faster, and there's better limb salvage rates and better bleeding rates with the use of the ultrasound-assisted catheter. However, you're still using lytics, and it's still not indicated in kind of late-stage presentations. There's also percutaneous manual thromboaspiration, which has largely been out of favor because this has a manual syringe that you hook up to, and under negative suction, you're kind of pulling out the clot. But these catheters are kink easily, they're low profile, and they're not very trackable. So largely been replaced by mechanical thrombectomy, in which in Mount Sinai, we've mostly used either the Rotarex, which is the top figure here, or angiojet. Basically uses some form of mechanical debulking of the clot and aspirates it as well. So in the case of the Rotarex, you have a helix that's kind of spinning that generates a vacuum, and these side ports that are basically aspirating the clot and debris as well. And in the case of the angiojet, you have these saline sprays, or you can also use TPA that kind of create a similar vortex, and you also have the aspiration ability with the motor. Limited by hemolysis, AKI, you're also a lot of blood loss with these, and there's also always a risk of vessel trauma requiring stenting. One of the more newer advances is also the aspiration thrombectomy. The Penumbra, the Lightning 7, has been the most recent iteration of it. It's available anywhere from 3 French to 8 French, so anywhere from the pedal arch to the aortoiliac arteries, you can use it. Pretty good preliminary data. You don't have to use lytics, and it's indicated really in native graft vessels, acute on chronic lesions, and also in-stent lesions. But it does result in blood loss with the aspiration, especially with the larger profile catheters. There's a newer, this one's still investigational, the JEDI catheter by Abbott. It kind of combining both the angiojet and the Penumbra, where you have a saline jet that's creating a hydrodynamic mechanical force and also aspirating at the same time. These are available 6 and 8 French catheters. Preliminary results were promising, but there's more data coming out with that. In general, all of these different therapies are institution and operator dependent. There's very few head-to-head trials. In general, seems like the mechanical thrombectomy is being favored, does result in better patency, less reinterventions compared to catheter-directed lytics or some of the older methods of a thrombectomy. In general, just quickly going over the management. So in general, if it's stage 1 limb, usually if early intervention is indicated, if their symptoms are worsening, what's preferred is either catheter-directed lysis or some sort of mechanical thrombectomy. And stage 3 usually requires a surgical consultation, possible amputation. And in case of 2A and 2B, generally the recommendation is some sort of mechanical thrombectomy first, with or without the lytics, as long as there's no contraindications. And another thing you want to just keep an eye out for is reperfusion syndrome. Once you revascularize, there is a profound inflammatory response from the breakdown of cell and rhabdomyolysis. So monitoring for compartment syndrome, monitoring the CK level for myoglobinuria, and having your surgical colleagues on board is going to be very crucial. That's it. Thank you.